Good afternoon, everyone. Today we begin our deep dive in Chapter 3, the Cardiovascular Disease, or CVD. To start, we must define the cardiovascular disease not as a single condition, but as an interrelated group of diseases. So, the definition cardiovascular disease is a group of interrelated disease, including atherosclerosis, hypertension, ischemic heart disease, peripheral vascular disease, and heart failure. The impact in the United States. The statistics are sobering. In the United States, roughly 84 million adult. That is one in every three people adult live with some form of cardiovascular disease. It remains the leading cause of death for both men and women, claiming more lives than cancer and accidents combined. Essentially, American dies from cardiovascular disease event every minute. Our goal as clinician is to understand how nutrition can break this cycle. To understand the scale of this epidemic, let's look at the specific breakdown of these conditions. In this table highlights the sheer prevalence of these diseases. Hypertension, look at here, is the most widespread, affecting an estimated 75 million people. Coronary heart disease affected more than 25 million people. Stroke, close to 8 million people. Heart failure, about 6.5 million people. Myocardial infarction, close to three quarter of million people. We also see high numbers of coronary heart disease and stroke. It is important to note that you can't simply add these numbers together to find the total population count. Why? This is the question. Because the comorbidities, this is the answer. A patient with hypertension often also has coronary heart disease or is at high risk for myocardial infarction. This overlap is hallmark of cardiovascular pathology. Before we discuss the diseases themselves, we must understand the biological, the pipes they affect. Anatomy and physiology of the blood vessels. Blood vessels are sophisticated organs composed of three distinct layers. Number one, the out layer provides structural integrity through connective tissue. Number two, the middle layer, composed of smooth muscle, is what allows for the contraction and dilation necessary to regulate blood pressure. And number three, the inner lining, endothelium, also smooth protective barrier between tissue and blood. However, in nutritionists, our primary focus is often the endothelium. Again, the endothelium is the inner lining. In healthy states, this layer is smooth and highly responsive, acting as a protective barrier. It is not just a wall, it facilitates the bidirectional passage of gases and macromolecules between our tissue and the blood. So the endothelium again facilitate the passage macromolecules and gases and release the bioactive substances like what? Like nitric oxide or NO. The health of this endothelium depend largely on a single soluble gas. So, what is the role of nitric oxide? NO. Nitric oxide or NO is the miracle molecule of the vascular system. It is synthesized in the endothelial cell from the amino acid L-arginine. Nitric oxide is essential for maintaining vascular homeostasis because it is a potent vasodilator. When nitric oxide production decreases, we see the endothelial dysfunction. This is the tipping point where the vascular balance is disrupted, leading to vasoconstriction, platelets activation, and localized inflammation. This dysfunction is often the first step toward atherosclerosis. When that protective barrier fails, the process of a plaque accumulation begins. What is the pathophysiology of atherosclerosis? Atherosclerosis is essential an inflammatory response to endothelial injury. Once the lining is damaged, monocytes move into the tissue and evolve into macrophages known as foam cells. These cells ingest oxidized cholesterol, which eventually forms fatty acid sticks within the vessel's wall. As the body tries to protect itself, the fibrin, the fibrin layer called atheroma forms over these deposits. Interestingly, the artery can remodel itself, enlarging to keep the passage open, but this can eventually weaken the wall and lead to a aneurysm. Let's visualize how these plaques change over time and the dangers they pose. The plaque progression and rupture. The mature plaque, like here in this figure, include lipid core and fibrous cap. This is the lipid core and this is the fibrous cap. Not all plaques are created equal. As you can see in this figure, we distinguish between stable plaque and unstable plaque. So stable versus unstable. Stable plaque has a thick fibrous look. There's a thick fibrous, like here thin. For stable, it is a thick fibrous cap and small lipid core. While it narrow the vessels, it is less likely to rupture. Conversely, the unstable or vulnerable plaques are much more dangerous. They have a thin fiber. There is a thin fibrous cap, and large volatile lipid core. When these rupture, they form a thrombus or a blood clot. This can lead to a sudden total blockage of the artery, resulting in a heart attack or stroke. So, this is the differences between stable plaque and or versus unstable plaque. The clinical symptoms for the patient experiences depend entirely on where this blockage occurs. Clinical manifestation of the athero, atherosclerosis cardiovascular disease or ASCVD. If it happens in the coronary artery, the atherosclerosis or atherosclerotic cardiovascular disease or ASCVD, the patient may experience angina or myocardial infarction. If the cerebral arteries are affected, we see a stroke or transient 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 ischemic attacks, TIAS. In the leg arms, it presents as peripheral vascular disease, causing intermittent claudication or, in severe cases, gangrene. It is all the same underlying process. Atherosclerosis just is different locations. To manage these risks, we must look at the lipid profile that drive plaque formation. So, understanding the dyslipidemia. Dyslipidemia is a blood lipid profile that significantly increases the risk of developing atherosclerosis. While we often talk about high cholesterol, the reality is more nuanced. Cholesterol is delivered into cell wall by low density lipoprotein or LDL. However, for that cholesterol to stimulate the foam cell we discussed earlier, it must first be oxidized. The oxidation is the key step in the inflammatory process. A typical dyslipidemic patient has high LDL and low HDL, high low density lipoprotein and low high density lipoprotein, high low density lipoprotein and low in high density lipoprotein. But we exactly are these LDL and HDL particles. Let's break down the lipoprotein classes. The classification and density of the lipoprotein. Lipids are not water soluble, so they must hitch a rid of on proteins to travel through the blood. We call these complexes lipoproteins. We classify them by density, which determined by the ratio of protein to fat. For the first, chylomicrons. Chylomicrons are the largest and least dense, carrying dietary fat from the intestines. At, other, at the other end of the spectrum, there is high density lipoprotein, the smallest and most dense because they contain the highest percentage of protein. While VLDL, the very low density lipoprotein, synthesized in the liver to transport endogenous triglyceride. And finally, the low density lipoprotein LDL, primary cholesterol carriers, and formed from VLDL breakdown. The behavior of these particles is dictated by specific protein on their surface. Apolipoproteins control is the metabolism of lipoprotein molecules. Apolipoproteins are the controls of lipid metabolism. ApoP is the structural protein for all atherogenic or plaque forming lipoprotein, including VLDL and LDL. On the other hand, ApoA1 is found in HDL. It is anti-inflammatory and acts as a vacuum, helping to remove cholesterol from the arterial walls and transport it back to the liver for excretion. In the clinical research, a lower ratio of ApoB to ApoA1 is generally associated with lower atherosclerotic cardiovascular disease risk. There is other two types. ApoC2 is a cofactor for lipoprotein lipase LPL, and there is ApoE helps receptors metabolize chylomicrons remnants. Now, let's look at how we measure these in a standard clinical setting. The standard lipid panel measures total cholesterol, which is the sum of cholesterol in all lipoprotein fractions. Most of it, about 60 to 70%, is carried LDL or low density lipoprotein, and 20 to 30% on HDL, and 1 to 15% on VLDL. We also measure the triglyceride. While buoyant VLDL particles are generally non-atherogenic, the smaller, very low density lipoprotein VLDL remnants are very dangerous because they activate the clotting cascade. Triglyceride level above 500 milligram per deciliter is a critical warning sign, not just for the heart, but for the risk of acute pancreatitis. For some patients, these levels are high regardless of diet due to their genetic makeup. Genetic hyperlipidemias, familial hypercholesterolemia FH, and polygenic. Genetic hyperlipidemiasis or hyperlipidemias can be severe. Familial hypercholesterolemia FH is characterized by extremely high LDL from birth, often leading to premature cardiovascular disease. We can sometimes spot this physically via xanthomas, cholesterol deposits on the Achilles tendon. Then we have polygenic, the polygenic FH, polygenic familial hypercholesterolemia means, which involves multiple gene defects. In these cases, we see two or more family members with LDL levels above the 90th percentile. While lifestyle changes are essential, these patients almost always require pharmacotherapy. So, again, the polygenic familial hypercholesterolemia result of multiple gene defects, and the common one is ApoE4 allele. The other genetic condition involve the overproduction of specific lipoproteins. Familial combined hyperlipidemia or FCHL is actually the most common primary dyslipidemia. It is usually caused by the liver overproduction or overproducing ApoP100. These patients often have other risk factors like obesity or metabolic syndrome. Finally, there is a familial there is a familial dys beta lipoproteinemia type 3 is actually the most common primary dyslipidemia. It is caused by the liver overproducing, the familial dys-beta lipoproteinemia is a rare condition, different from the familial combined hyperlipidemia. Is a rare condition where the body fails to clear chylomicrons, remnants because of a specific variant of the ApoE. These patients often present with both hyper or high cholesterol and high triglycerides. How do we move from these blood tests to definitive medical diagnosis? The initial diagnosis often start with non-invasive tests like electrocardiogram or ECG or stress tests. However, the gold standard for looking at blockages is angiography. We inject a dye into the arteries and use radiographic image to see exactly where the narrowing is. We can also use electron beam CT to look for calcium deposits in the arteries. Positive scan is a very strong predictor for future coronary events. It is important to remember that many heart attacks happen in arteries that were only mildly obstructed, which is why detecting vulnerable plaque is so critical. As we move into the prevention, we must identify which risk factor we can change. We divide the risk factor into modifiable and non-modifiable. Modifiable factor and non-modifiable factors. Modifiable factors are where we as a nutritionist have the most impact. This include LDL levels, blood pressure, smoking, and obesity. Non-modifiable factors like age and family history cannot be changed, but they help us to determine how aggressive our treatment needs to be. For example, a man over 45 years or a woman over 55 is automatically at higher risk. We use these to create a 10 years risk profile for the patients. Beyond simple cholesterol, new markers are helping us find hidden risks. Did you know that 50% of heart attack happen in people with normal cholesterol level? Why? This is why we look at the inflammatory markers. The C reactive protein. High sensitive C reactive protein is acute phase reactant. If it's over 3 milligram per liter, it is a significant indicator of vascular inflammation. We are also learning about TMAO. This is a metabolite produced by the liver after gut bacteria digest animal protein. High TMAO levels can predict cardiac risk even when traditional tests look normal. This provides strong arguments for the benefits of a plant-based diet. Another metabolite often discussed is homocysteine. Homocysteine and cardiovascular risk. Homocysteine is amino acids metabolite that has been regarded as independent risk factor for cardiovascular disease. While we can lower homocysteine levels by giving B vitamins like folic acid or like B6 pyridoxine or like B12 cyanocobalamin, large clinical trials have mostly failed to show that this actually reduces heart attack risk. This suggests that homocysteine might be a marker of disease rather than direct cause. For now, it is not widely recommended standard treatment, but it remains an active area of research. To simplify all these factors, for the public, the American Heart Association, EAHA, created a simple framework. The Life Assemble 7. Life Assemble 7 is a graphic, is a powerful tool for patient education. It focuses on four core behavior: diet activity, weight, and smoking, and three heart factors: cholesterol, blood pressure, and glucose control. By the following these seven steps, a significant number of coronary events could be prevented. This figure serves as a checklist for both professionals and consumers to gauge their heart healthy journey. Let's look at the specific dietary pattern recommended by these guidelines. The American College of Cardiovascular Disease, ACC, and American Heart Association, AHA, lifestyle recommendation. Number one, diet. The 2013 guidelines moved away from focusing on individual nutrients to, to wear dietary pattern. The goal is a diet rich in vegetables, fruits, whole grain, and lean protein like poultry and fish. Crucially, we want to limit sweet and red meats. These patterns should be adapted to the patient's cultural preferences and caloric requirements. We generally recommended following the DASH or AHA dietary pattern to achieve these results. Beyond the types of food, we must also consider fat quality and physical movement. When it comes to the fat, the recommendation is strict. Aim for only 5 to 6% just of the total calorie from saturated fat. We also want to reduce the trans fatty acid as much as possible. For physical activity, the, the prescription is 3 to 4 sessions a week. Each session should last about 40 minutes and involve moderate to vigorous intensity. This is not just for weight loss, it is directly improve lipid and lower blood pressure. One of the most evidence backed patterns for this is the Mediterranean diet. The Mediterranean diet is not just one diet, but a pattern of eating. It emphasized fresh produce, fatty rich in omega 3, like salmon, like sardine, like the tuna, and also nuts and healthy oils like olive oil or canola oil. It is a moderate fat, about 32% to 35%, but very low in saturated fat. The Prevalence trial was a landmark study that showed this diet could reduce the risk of the major cardiovascular disease events by 30%. It is essentially the gold standard for the cardio protection. Another powerful option is the DASH diet, which was specifically designed for the blood pressure. DASH stand for dietary approach to stop hypertension. It is high in fruits and vegetables and low in fat dairy. Research shows that replacing 10% of carbohydrates in the DASH diet with either a protein or unsaturated fat provides even better result for the heart. We should also mention the vegan diets. While 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 the very restrictive, some research suggests that strict whole food plant-based diet can actually reverse existing atherosclerotic disease, though more studies are ongoing. A major driver for all these conditions is the global rise in obesity. The impact of obesity on heart health. Obesity is an epidemic that directly feeds into every major cardiovascular risk factor, from hypertension to sleep apnea. Many of the inflammatory proteins we have discussed actually originate in the adipocyte or the fat cell. We also look at the fat distribution. The central or abdominal obesity is strongly linked to inflammation markers like high sensitive C-reactive protein that I mentioned earlier. This is why we recommend waist circumference of less than 35 inch for women or 82 centimeter or 40 inch for men or 102 centimeter. Even the modest weight loss of 10 to 20 pounds or 5 to 10 kilogram can significantly improve patient's lipid profile. So, how do we implement these changes as practitioners? This is why I will discuss it in the next part 2 for the medical nutrition therapy for the cardiovascular disease. See you later and goodbye.